Hi, good evening everyone. How are you all doing? Perfect. So we started our day today with the soothing voice of Dr. Srinath. I know it just feels so right just to hear him. Then you went on to our wittiest Dr. Achin sir and you got blasted by the CNS. Then you had the god of medicine, our own Dr. Arvind sir. And now just to relax you guys a bit, you guys wanted a break. So anesthesia, as we know, it's a break for us. Yes, the color of CSK, yes, everything. You guys are too witty for me to understand. And for all those people who are asking कि sir आप dance कब करोगे? तो remember मैं नचाने नहीं, मैं सुलाने का specialist हूँ. So that is what I specialize in doing. So we are going to discuss anesthesia. You know, anesthesia is a very easy peasy subject. We have always discussed it this way. We are going to finish it very quickly. We have 1 hour and it's a DAMS visual treat. So we are going to start with things that are to look at and then we will discuss everything in a very, very integrated manner. All right. So let's start with first critical care and CPR. Why I have started to introduce this as the first topic? Because this has practically become now the most important topic for your exam. All right. We do get a lot of questions from critical care these days and we also get a lot of questions from CPR. CPR is a must know topic for your exam. So this is straightforward. The oxygen delivery systems, how you deliver oxygen, low flow systems and high flow. Low flow is defined as less than 15 liters per minute flow rate of oxygen and more than 15 liters per minute is considered as high flow. Okay. Low flow, the example are nasal cannula, Hudson's face mask, non-rebreathing mask. High flow is Venturi mask, high flow nasal cannula and CPAP or BiPAP. Now remember, unless and until specified high flow nasal cannula, you will always consider a nasal cannula as a low flow nasal cannula. Try to understand. Only when it is written HFNC is when you will consider it as a high flow nasal cannula. Otherwise, for all practical purposes, nasal cannula means low flow nasal cannula. How do they look? More or less we know how they look, but just for your remembrance, nasal cannula looks like this as compared to a high flow nasal cannula which looks like this. It is a broad strip kind of a thing that comes with a machine. I'll show you the image of a machine as well. Then you have face mask called as Hudson's mask. You have Venturi face mask. You have face mask with reservoir bag. Now the name is only telling plain face mask, simple face mask. So it has only face mask in it, right? Then you have Venturi mask. So it works on the principle of Venturi. Remember, you will always see a valve with the mask. You will always see a valve with the mask. All right. Third, face mask with reservoir bag. So you will always see a reservoir bag which gives you highest FiO2. Which gives you highest FiO2. If somebody asks you in oxygen delivery devices, which device gives you highest FiO2, that would be NRBM, non-rebreathing mask. Then you have these devices which are through which you can give CPAP or BiPAP. Oronasal, that is a NIV mask, which is a oronasal mask. It covers the nose as well as the face. Then you have a nasal NIV, which is predominantly used for patients of obstructive sleep apnea. जिनको घर पे रखते हैं हम, home NIV. Usually that is a nasal NIV. This full face mask is rarely used these days because this is very claustrophobic for the patient. Helmet is used for patients in which you can't really help. You can't tell them how to do, when to do, what to do. That is pediatric patients. All right. Out of all these airway devices, oxygen delivery devices, only Venturi mask is a fixed O2 delivery device. It is only fixed O2 delivery device. All right. Fixed means the FiO2 delivered to the patient is fixed, irrespective of what the breathing status of the patient is. Okay. Irrespective of what the breathing status of the patient is, the FiO2 that is delivered is fixed. All right. Next is high flow nasal cannula. Now this is an in thing and pediatricians have been using this for a very long time. In pediatric, in neonatal critical care, there is a very big role of HFNC. They also call it bubble CPAP, BiPAP. whatever. But now its use has been put in adults as well. High flow nasal cannula is a ventilator type of device. When I say type, the machine looks like it is the machine that is like a ventilator type of a machine. It's a big machine. It has flow meters with oxygen and air, that is a gas blender. Then there is a device, the system to generate that high flow, and then there is a cannula that is put on the patient. The important thing is high flow, fixed performance, heated and humidified oxygen. Heated and humidified, this is the word that you have to really remember, heated and humidified. So it heats up and it humidifies that air and then delivers it to the patient. Advantages: easy to use, minimal risk of gastric distension, can deliver high FiO2 and even some positive pressure, that is PEEP. Good humidification, so it helps in mucociliary clearance and may help avoid intubation. And when you say may help avoid intubation, that means in the flow, in the chain of things, the patient, when he's received, maybe he requires oxygen through face mask, then you go to NRBM, then before you decide to actually mechanically ventilate the patient, you can give a last try of HFNC. That is what it means, that it may help avoid intubation, but sometimes putting the patient on HFNC delays in intubation. So that is one of the disadvantages, that it has a potential to delay intubation and invasive ventilation. Sometimes your patient might be deteriorating, you might keep on feeling, okay, let's continue, and that is where you might delay intubation. Requires heating and humidification, so obviously it requires power source. It is expensive, it's not a cheap device, and it requires intermediate pressure of oxygen, so it cannot be used in all the places. That means if you don't have an intermediate pressure source in inside your ICU, then you might not be able to deliver oxygen through this device. All right. Next, let's come to indications of NIV. NIV is through that NIV interface, and that is indications of NIV. Just remember one indication, most important indication is acute hypercapnic exacerbation of COPD. Acute hypercapnic exacerbation of COPD. That is the most important indication. You can mark it. You will 90% of the time get a question in the exam where there will be a clinical picture of acute hypercapnic exacerbation of COPD. A 60-65-year-old COPD patient presented to your casualty with respiratory rate of 30 breaths per minute with a saturation of say 88% and a PCO2 of 65. What is the next step you do? This is the question that has already been asked in exam few times. The first thing that you will try to do there is you will put an NIV interface. Second is obstructive sleep apnea, obesity. In that there is a role of NIV. And in acute respiratory failure, if the patient's consciousness is good, then you might first want to put the patient on NIV and then only on invasive mechanical ventilation, right? Invasive mechanical ventilation. Next is invasive mechanical ventilation. Now what I have done this time is, rather than taking you through the entire process, I am trying to integrate from question perspective. What is that they are expecting you to know? So whenever they give a question on invasive mechanical ventilation, what do you mean by invasive mechanical ventilation? Endotracheal tube, tracheostomy tube. When you deliver the breaths using a invasive airway. Invasive airway is one that breaches the body cavity, which is trach and endotracheal tube. That is called as an invasive mechanical ventilation. All right. So look at the modes of ventilation. What are they expecting to know? Modes, algorithm, initial ventilator settings, and how you wean the patient off. All right. Next is modes. So now again, this is not something that you would see in any of the textbooks of critical care. This is how you would approach a mode question. They will ask you either a control mode or a weaning mode. Weaning means when you are allowing the patient to breathe spontaneously. Control means when the ventilator controls all the aspects of the breath, right? Second, wherever you see the word controlled is a controlled mode of ventilation. Wherever you don't see a control, then might be a meaning mode of ventilation. And here you have two examples, control, assist control. Here you have two examples, SIMV and pressure support ventilation. Understood? So this is for your understanding ki, okay, if a question comes, which of the following is a weaning mode of ventilation, look at these three things. If comes, which of the following is a controlled mode of ventilation, look at these three things. Algorithm of mechanical ventilation. Now this algorithm is for you to understand how you clinically approach a question of ventilation. So for whatever reason the patient reached your ICU, you tried non-invasive methods of oxygen delivery. You put on oxygen mask, the patient was not maintaining, you put on NRBM. The patient was not maintaining, you put the patient on HFNC. So you first start with non-invasive O2 delivery. That is the first thing you try in most cases. When you fail at maintaining the patient, then you start with invasive ventilation. And initially, for intubation, you most likely have to give muscle relaxants. So you start with controlled mode. So when you fail with non-invasive delivery, you start with control mode. Okay, control mode. After you have passed that initial phase, you try to improve on your pathology. Then you go to weaning modes. Weaning modes. From there, you go to spontaneous respiration. And then you extubate. So try to understand the chronology here. Initially you try to manage non-invasively, then invasive may control, then weaning, that is you are allowing the patient to breathe so that the patient has that strength to come out of mechanical ventilation. Then you leave the patient on spontaneous respiration, you extubate, and after extubation you put the patient on non-invasive outflow delivery for some time. Remember this thing in general. In general, you get a patient, this is the algorithm you have to follow most of the time. Okay. Stuck हो गया? हाँ, ठीक. Alright. Then a question that is asked is initial ventilator setting. Initial means when you are here. When you are here at the level of invasive ventilation. Initial ventilator setting. So mode will always be assist control mode. Assist control mode. The mode would be assist control. Tidal volume, respiratory rate. Tidal volume, respiratory rate. Tidal volume, respiratory rate. Okay. So how much tidal volume? So we think in terms of numbers. So normally we say between 12 to 16. है ना? Sorry, tidal volume we say in terms of ml per kg. So 6 to 8 ml per kg. Respiratory rate we say in terms of number 12 to 16, but that is not the idea. The idea is the respiratory rate is decided according to the tidal volume and the minute ventilation, that is to keep a target PCO2 that is normal. That is between 35 to 45. So the rate should be to keep the PCO2 normal. So it's always in guidance with ABG. FiO2 start with maximum 100%. And then you decrease to optimum level. What is optimum level? An SpO2 of 94%. Saturation of 94%. So you start with 100%, you start decreasing it, decreasing it, keep it to the point where your saturation is more than 94%. More than 94%. Next is PEEP. Positive end expiratory pressure. Positive end expiratory pressure. This is for alveolar recruitment. This is for alveolar recruitment. So you start with PEEP of 5 and you can go up to 15. But you start with a minimum PEEP of 5 centimeters of water. 5 centimeters of water. 5 centimeters of water. Inspiratory flow rate you keep between 60 to 80 liters per minute. Again, minute ventilation that is required to deliver to the ventilator. 60 to 80 liters per minute. 60 to 80 liters per minute. Yes, I'm looking at the chat box. If I find something that what I am doing is what you are probably asking me. Whatever I am not discussing here, most of the chat questions are regarding that only. So you have to understand this is a revision thing. I can't keep on explaining you everything. I am wanting you to integrate. I think I gave you this PDF yesterday. I saw a lot of posts regarding the PDF. So I'm going to again tell to all those students who did not follow my PDF that I am giving to you. And this is not a PDF for your exam. This is a PDF for your life. That is patience, discipline, and faith. This is the PDF that you want. Most important quality you should have is patience. Everything that you need for this exam is right in your hands. We have given you a printed workbook. Everything will be uploaded in time. You guys know that. We have been through this till 100 times. Everything gets uploaded. Everything is there. There's nothing that you don't get. In fact, whatever we give you, most of the times you're not able to complete it. You need patience. Discipline. Listen first. You don't know what I'm going to say next. Do you know that? No. Discipline. Try to calm down and look at the topic in hand rather than always asking or thinking about something else. And faith. Faith is for here. Trust the process. Everything that you need is there. You just need to have faith that okay, whatever we are discussing, whatever we are trying to understand, things are going to come from it. Understand? So this is my PDF to you. Keep this PDF. This is the most important PDF you are going to get in your life. All right. So weaning modes of ventilator. Weaning modes of ventilator. Best mode of weaning, pressure support. Pressure support. Pressure support ventilation, also called as PSV. Best mode of weaning, pressure support ventilation, PSV. All right. Spontaneous breathing trial. Spontaneous breathing trial. This is a mode. Mode is on ventilator. After the patient has improved on this, now you remove that mode and you put the patient on spontaneous breathing trial. That is done 15 minutes to 30 minutes. And then check ABG. And then decide extubation. So you leave the patient for 15 to 30 minutes on spontaneous breathing trial. Spontaneous breathing trial. All right. And then success of weaning is decided by an entity called as RSBI. Rapid Shallow Breathing Index. Rapid Shallow Breathing Index. RSBI. This decides your success of weaning, which is the respiratory rate of the patient divided by tidal volume in liters. Respiratory rate by tidal volume in liters. It has two interpretations. If it is more than 100, that is weaning failure. If it is less than 100, it is weaning success. That means you can successfully wean the patient off. So these are things for weaning. One, mode. Second, spontaneous breathing trial. Third, how do you predict the success of weaning? How do you predict the success of weaning? All right. All right. Chalo, good. Next. Now this is algorithm for oxygen delivery devices. Whatever we have discussed till now, I have again put it in a table. Now calm down, everybody. For the next 3 minutes, just keep looking at me. This is a table with you forever because it is in your DVT workbook. It doesn't have legs. It is not going to run away. It's going to be there. You know how to read English. So even if I don't teach you this, you are anyway going to understand. Try to understand it from a clinical perspective. Alright. This is algorithm. Oxygen therapy. Patient comes with severe respiratory compromise or impending arrest, respiratory or cardiac. Immediately intubate. That is what you will do. Patient is not maintaining at all. GCS less than 8. Risk of aspiration. Patient has massive injury. Patient is in frank pulmonary edema. There is a massive myocardial infarction. Immediately intubate. If no, then you see, is there a risk of type 2 respiratory failure? That means there's a problem with CO2 elimination. If it is yes, then your target SpO2 between 88 to 92%. See, target SpO2 88 to 92%. If there is a risk of type 2 respiratory failure, that means it is COPD patient. That means you need to control the oxygen giving. Start with Venturi mask. Venturi mask to maintain a saturation above 94. Obtain ABG. If FiO2, SpO2 more than 92, then look at ABG. If pH is less than 3.7.35, that is acidotic patient, PCO2 more than 45, your therapy is not working. Then you consider NIV. If it is pH more than 7.35, PCO2 less than 45, your therapy is working. You will treat with Venturi mask. Try to keep a target SpO2 88 to 92%. Keep repeating ABG at least half an hour to 1 hour later. If there is no risk of type 2 respiratory failure, then your target SpO2 is 94 to 98% because the patient is not COPD, you can give more oxygen to the patient. Okay. If the SpO2 is between 85 to 94, you check ABG. And with that you start nasal cannula. I told you the first thing you start is nasal cannula or simple face mask 5 to 10 liters per minute. If your ABG, the patient's ABG is less than 85, you check ABG and you start reservoir bag. Now you want to give higher FiO2. If PCO2 is more than 45, with this condition, that means it warrants invasive mechanical ventilation, or you decide after some time what it is. So this is a very, very simplified table for you. For all future these types of questions, talk to this table. Always remember that is the best way to talk to the table. Alright. CPR. Now this is a straightforward topic. We have discussed this so many times. So we are going to quickly go through it. First thing, CPR is done in an event of cardiac arrest. Whenever you have an event of cardiac arrest, what do you know? What do you do? You have to follow certain things to improve the chances of survival of a cardiac arrest victim, right? So these are the 6 steps, critical steps in the chain of survival. 2 conditions: outside hospital cardiac arrest, in hospital cardiac arrest. Outside hospital cardiac arrest, first thing is activation of emergency response system, followed by high quality CPR, followed by defibrillation, followed by advanced resuscitation, then post cardiac arrest care and recovery. In hospital cardiac arrest, because you know what kind of patients are going to undergo cardiac arrest, the first step would be always to recognize and prevent. You don't want the cardiac arrest to happen, but if it happens, then activate ERS, call for help, and high quality CPR, defib, advanced post cardiac arrest care, because here in hospital directly your CPR is your advanced care, and then recovery. You might wonder what is recovery. Include additional treatment, observation, rehabilitation, psychological support. That means a patient came to you in cardiac arrest, you manage the patient, you put the patient in ICU, the patient there was for 15 days, you discharge, you gave a fat bill to the patient, send him home, and then you call him up and ask, Bhaiya theek ho? Theek lag raha hai? That is what recovery. It's all the PSM stuff. Okay. We know CPR is as easy as CAB. Most important priority, compressions, followed by airway, followed by breathing. Remember, compressions are most important priority. That is why in the exam, we get most commonly the questions from the chest compressions. 5 do's and 5 don'ts of high quality CPR. What are the do's? Compression rate 100 to 120, not less than 100, not more than 120. Depth at least 2 inches, that means not less than 2, not more than 2.4. Allow full recoil between the compression, that means do not lean on the chest between compressions. Minimize pauses in the compression. It should not be like you do 3 compression, then take out your phone, take a selfie, okay, doing my first CPR, feels good, YOLO, and minimize it to less than 10 seconds. Adequate ventilation. Do not over ventilate the patient. That means for every 30 compressions you give 2 breaths. Okay. Difference in pediatric and adult CPR. Very easy and an important table. 5 points of difference between adult and pediatric CPR. The first is the point from which maximum question comes in your exam. How do you activate ERS? In an adult, it is simple. You see a patient, you activate ERS first, tell them to get an AED, then start CPR. In pediatric also, if you have witnessed the collapse, you will do the same thing. But if there is an unwitnessed collapse in a pediatric patient, then you will first give 2 minutes of CPR, then leave the victim and go call for help. Why? Because most common causes of cardiac arrest in pediatric patients are respiratory rather than cardiac. So you need to first give 2 minutes of CPR. It is potentially life-saving for the baby. Then compression to ventilation ratio, we know adult 30:2, pediatric. If there is one rescuer, 30:2, but 2 or more, you want to increase the number of respiration, 15:2. With advanced airway, here 1 every 6 seconds, here 1 breath every 2 to 3 minutes. 2 to 3 seconds. Depth of compression. 2 to 2.4 inches. In child, about 2 inches. In an infant, about 1.5 inches. Hand placement. Lower half of sternum for an adult. For a child, it depends, 1 hand or 2 hand, depending on the size of the child. Infant, if it is 1 rescuer, then it is 2-finger technique. Not 1 finger, it is 2-finger technique. 2-finger technique. But if you are 2 or more, then you do a better technique, that is a thumb encircling technique. So you'll hold the infant in the thumb and then do CPR. Okay. Airway, remember, always go from most basic to most advanced airway. Most basic airway, opening up of patient's own airway, head tilt, chin lift, jaw thrust. Head tilt, chin lift, jaw thrust. When you do 3 things together, head tilt, chin lift, jaw thrust, mouth open, it is called as triple maneuver. AIMS question 3 years back. Another change, another position, MILS, manual inline stabilization, that is done in suspected cervical spine injury patients. Suspected cervical spine injury patients where you do not have a hard collar in place, or you cannot place an hard collar because you have to intubate. There, somebody else will stabilize the cervical spine. How do you differentiate between MILS and any other position? In MILS, see, the hands are coming from the leg end because someone else is doing MILS. The intubator, the person who is backmasking the patient is not doing MILS. Somebody else is doing the MILS. So remember, the hands are always going to come from the side, the leg end of the patient. Okay. Now, 2 types of defibrillators. What is this? Automated external defibrillator used in BLS. One simple device, switch it on, it will analyze, it will deliver the shock. Manual defibrillator used in ACLS. This is the crux of cardiac arrest rhythms. 2 rhythms that are shockable, which is VF and VT. 2 rhythms that are non-shockable, pulseless electrical activity, PEA, and asystole. Which is the most common cardiac arrest rhythm? Asystole. Most common cardiac arrest rhythm? Asystole. Tell me, which is the most defibrillated or shocked rhythm of Bollywood? Asystole. You see that in movies? Very wrong. There the hero, he talks to everyone, then there is a flat line, then the doctor runs, he gives 1 shock, 1 QRS, then the heroine runs, holds the hands, 3-4 more QRS. He is going to die there only. Non-shockable rhythm. Alright. Now we'll talk about BLS and ACLS algorithm. What is the first step in BLS? Verify the scene safety. Why? So that the rescuer should not become the victim. So remember, first step, verify the scene safety. दूसरों की जय से पहले खुद को जय करें. बचपन में गाना गाते थे ना, हमको मन की शक्ति देना. This is what it is. First, see whether you can approach the patient safely or not. It should not happen that you only get caught up. Then check for responsiveness. Check for responsiveness. Hello sir, hello ma'am, bhaiya, didi, auntie, mummy. उठाओ. क्यों? Maybe he is not in cardiac arrest. He is just simply lying by the road. है ना? Common example, got beaten up by wife. Then you would not call for help. You will call for wife. So check for responsiveness. If there is no responsiveness, then shout for help. Tell them to get an AED and then check for pulse and breathing. So pulse and breathing check is the fourth step in the algorithm of BLS. Okay. 3 conditions. Normal breathing, pulse felt. That means the patient is not in cardiac arrest. There is some other problem that you need to figure out. So unconscious patient with pulse and breathing present, you put him in recovery position. Recovery position. You turn on one side, one hand over below the cheek, another hand straight or like this, one leg over other. Safest position for a unconscious patient with pulse and breathing. Second is rescue breaths. That is when pulse is present but no breathing. So you will simply give rescue breaths, and only when there is no pulse, no breathing, or only gasping breathing, then you will start CPR. You will give CPR in the cycles of 30:2, 30 cycles followed by 2 breaths. You will give 5 such cycles in the hope somebody would have gotten an AED by that time. You will attach AED if the rhythm is shockable, press shock. Immediately after the shock, again continue CPR. If it is not shockable, continue CPR. Till what point will you do? Till 3 things happen. What is the first thing? You were successful. The patient is revived. Patient will get up. He will say thank you to you. He will go. Second, you got tired. There was not help. The patient didn't revive. You will say sorry to the patient. You will go. Third is that help that you called. That help has finally arrived. So they will say thank you to you. You will leave the victim. They will take over. They will immediately start CPR, because an ACLS team always reaches in a scenario where the diagnosis of CPR, the cardiac arrest has been done. So they will start CPR, give oxygen, attach monitor, defibrillator. If the rhythm is shockable, they will immediately shock. Immediately after shock, somebody will start taking IV, IO access. If the rhythm is shockable, they will press shock, then give drug of choice, that is epinephrine, every 3 to 5 minutes. Again, after 2 minutes, they will analyze rhythm. Rhythm is shockable. Now, second drug of choice, that is amiodarone or lignocaine. Both are now second drug of choice. At any point of time, if the rhythm is non-shockable, now the guideline is give epinephrine ASAP and continue CPR and keep giving epinephrine. In the meantime, your team leader will start thinking in terms of how to reverse this cardiac arrest. So he will start taking history, looking at patient's age, whatever information he can gather, and try and rule out the 5H and 5T, that are the 10 reversible causes of cardiac arrest. That is hypovolemia, hypoxia, hydrogen ion or acidosis, hyperkalemia, hypothermia, and T, tension, pneumothorax, cardiac tamponade, toxins, pulmonary and coronary thrombosis. Okay. ROSC, return of spontaneous circulation. That is, you have done a good job. Pulse and BP will come back. Abrupt sustained rise of EtCO2 to more than 40 and spontaneous arterial waveforms in intra-arterial monitoring. Alright. Drug therapy in CPR. Adult is very, very important. Adult dose 1 milligram. Dilution 1 in 10,000. What do you mean by 1 in 10,000? You take 1 milligram per ml, dilute it till 10 ml every 3 to 5 minutes. How many doses? Infinite. If you are giving the same thing endotracheally, you need 2 to 2.5 times dose. This you dilute in 10 ml just for better drug delivery. But this is a undiluted 2 to 2.5 times dose that you take. So you take 2.5 ml adrenaline, you dilute it till 10 ml and push it through the endotracheal tube. Amiodarone, first dose 300 milligram, second 150. Lignocaine, first 1 to 1.5 mg per kg, second 0.5 to 0.75 mg per kg. Okay. Alright? Very important condition. This is recent favorite. Foreign body obstruction. There are two types of foreign body obstruction, partial, complete. Partial is when the patient can vocalize. Okay, the patient can vocalize. If the patient can make no sound or the patient makes universal choking sound, then it is called as complete airway obstruction. You will only treat complete foreign body obstruction to age group less than 1 year, more than 1 year. More than 1 year, you give Heimlich's maneuver, go behind the back, make a fist, give subdiaphragmatic thrust. Less than 1 year, 5 back blows, 5 chest compressions. Okay. Now we move on to the core anesthesia part. Let's now come to DVT, visual treat. So let's look at images and graphs. What is this position? Barking dog or sniffing position. That is ideal position for intubation. Ideal position for intubation, isn't it? What happens? There are two positions, extension, flexion. Extension at atlanto-occipital joint. Flexion at lower cervical joints. Extension at atlanto-occipital joint. Flexion at lower cervical joints. Pediatric doses, if you can, then you should remember, not very important. Age for Heimlich, more than 1 year. Less than 1 year, you give 5 back blows, 5 chest compressions. Okay. Alright. Acha, one thing I wanted to tell you. Very good. You will give Heimlich's maneuver only when your patient is responsive. During your management of foreign body obstruction, if your patient becomes unresponsive, then what will you do? CPR. Remember, unresponsive means cardiac arrest has happened. Unresponsive means cardiac arrest has happened. So, in an unresponsive patient, in an unresponsive patient, in the management of foreign body obstruction, you will not give Heimlich's maneuver, but you will give CPR. Remember this thing. Okay. So the first position is barking dog or sniffing. Ideal. We know ideal things are not very applicable. So when you have a obese patient, you give help or ramp position. You give help or ramp position. What is help? Head elevated laryngoscopy position. You give head elevated laryngoscopy position. Okay. Yes, ear comes in line with suprasternal notch. You ramp the patient up so that the ear comes in line with the suprasternal notch. Ear comes in line with suprasternal notch. Okay. Ear comes in line with suprasternal notch. This is first position. Next is airways. Let's start with the first airway. Oropharyngeal and nasopharyngeal. This is how it looks like. Oropharyngeal, also called as Gudel's airway. Gudel's airway. Nasal airways, nasal airway. The most important question, just like you give breath normally, you try to give breaths. If it is getting delivered fine, it is not, then chest compression. Just keep doing chest compressions. Okay. Just keep doing chest compressions. How to choose an appropriate size of oral airway? How to choose an appropriate size of oral airway? So it is angle of mandible, central incisor. Distance between angle of mandible and central incisor. For nasopharyngeal airway, tragus to tip of nose. Tragus to tip of nose. Tragus to tip of nose. That is the most important question that is being asked in this topic. Tragus to tip of nose. That is choosing the correct size of the oropharyngeal and a nasopharyngeal airway. Choosing correct size of oropharyngeal, nasopharyngeal airway. Next we come to laryngeal mask airway, also called as supraglottic airway device, LMA, SAD, EAD, extraglottic airway device or EGA. This is first generation. What is the example? LMA classic. First generation, LMA classic. Then you have second generation devices. Second generation. What is the difference between first and second generation? What is the difference between first and second generation? This is the first time somebody has asked me upper or lower incisor. I will give full marks to their imagination. Distance between angle of mandible between upper and lower incisor would be different. It would be different if it is upper or lower. I'll give 100 marks for imagination, but okay. Yes, second generation have two tubes. You have one ventilating tube and you have one gastric drain tube. Ventilating and gastric drain. Three examples: ProSeal, Supreme, iGel. ProSeal, Supreme, iGel. How do you identify? ProSeal, no shape. No shape. Can you see? There is no shape. If it is anatomical shaped, Supreme. If it has no cuff, it is iGel. No cuff, iGel. Now you have a special LMA called as intubating LMA. You can intubate trachea using this LMA. Intubating LMA. This is called as LMA fast track. This is called as LMA fast track. This is a intubating LMA. You can intubate LMA. You can intubate a person using this LMA. Okay. Alright. Chalo. Next is laryngoscopes. Two basic shapes of laryngoscope: Macintosh, curved blade laryngoscope; Miller, straight blade laryngoscope. Most common blade, Macintosh. Miller is used for pediatric intubations. There is nothing to repeat in iGel. If you do not have a cuff in your LMA, that is a cuffless LMA, that is iGel. Okay. Cuffless LMA, that is iGel. No LMA can prevent aspiration. Aspiration can happen with any LMA. Second generation would obviously be better than first generation. Technique. In which hand do you hold the laryngoscope? Always remember, left hand. Don't say that you can hold the laryngoscope in non-dominant hand. No, left hand. Insert from right angle of mouth. Right angle of mouth. Right angle of mouth. Applied force forwards and upwards. Remember, use shoulder. Forwards and upwards. Use your shoulder. Most common complication, trauma to upper central incisor. Trauma to upper central incisor. Upper central incisor. So hold left hand, insert from right angle of mouth, sweep the tongue towards left, lift using your shoulder forwards and upwards, intubate from your right hand. Most common upper central incisor, when you use your wrist, when you put leverage, you use your wrist, that is when you get most common complication. Alright. endotracheal tube. This is how endotracheal tubes look like. Patient end has three things: bevel, Murphy's eye, cuff. Bevel, Murphy's eye and cuff. Okay. Bevel improves visualization of vocal cords. Murphy's eye, second ventilation port. Second ventilation port in case your main lumen is blocked, and cuff prevents aspiration. Cuff prevents aspiration. Okay. Which type of cuff is most commonly used? Low pressure, high volume cuff. What is the material from which this cuff is made? PVC. The material from which this cuff is made? PVC. See, don't sweat too much about what you are writing. If you are able to write, fine. If you are not able to write, it's okay. You are going to get this annotated PDF na? After you get my PDF, right? So don't worry about it. Just focus on listening. Yeah? Your chat box, you know, it's much faster than I can comprehend or read. So don't mind if I can't really answer to anything, because it's just moving just too fast for my understanding. My focus is right now on giving you what I've come here to give you. So just calm down, everybody, just calm down, just relax and just listen to me. Okay. Capnography. Now, very important table. Very, very important table. This is the table that will solve all the questions of capnography for you. Whenever you get a question in the exam, always look at AtCO2, the value. If the AtCO2 is less, hypocapnia, or it is more, hypercapnia. Hypocapnia less than 35, hypercapnia more than 45. If it is hypocapnia, then ask yourself whether it is developing gradually or suddenly. If there is a gradual hypocapnia in a patient and the hypocapnia is decreasing, it is mostly due to hyperventilation or hypotension. But if it is a gradual hypocapnia which is going to zero, that says it is esophageal intubation, that is ill-sustained capnography because your tube is in the wrong place. If there is sudden hypocapnia, the position of the patient is sitting or a head and neck surgery, then this points towards venous air embolism. But if there is a sudden hypocapnia that goes to zero, that points towards all the causes of flat capnogram, that is disconnection, cardiac arrest. If there is hypercapnia, then ask yourself whether it is developing gradually or suddenly. If it is gradual hypercapnia and the graph still touches the baseline, mostly it is hypoventilation graph not touching the baseline, all the reasons for rebreathing. If there is sudden hypercapnia which is seen intraoperatively, points towards a complication called as malignant hyperthermia. If it is during CPR, then it points towards ROSC. ROSC. Okay, return of spontaneous circulation, ROSC. So this table describes everything that you need to remember in capnography except one where the value doesn't really matter. The value can be higher, it can be lower, but the shape of the capnograph decides what is the condition. If there is a steep expiratory phase which looks pretty much like the fin of the shark coming out of water, then this is a shark fin appearance on capnography, which is something which is seen in COPD, bronchospasm, upper airway obstruction. COPD, bronchospasm, upper airway obstruction. All the tables that I am giving it to you, I am only introducing these tables to you. You have to talk to these tables just the way I am talking to you, and you will never forget a point from it. You take it in writing from me. So remember, these tables are extremely high yield. 5 minutes you spend with the table and your job is done. What is this? What is this? Neuromuscular monitoring. Neuromuscular monitoring, right? This image has come in the exam and they have asked what is the nerve being monitored. Can you tell me what is the nerve being monitored? What is the nerve being monitored? Yes, it is ulnar nerve, which is the most common nerve used to monitor neuromuscular monitoring. The muscle used is adductor pollicis. Adductor pollicis. This question has been asked many times. What has not been asked and can be asked is the second most common nerve, which is facial nerve, and the muscle is orbicularis oculi. This has never been asked, so this is a potential question. This is a potential question. Then 3 methods of recording of response: mechanomyography MMG, acceleromyography AMG, electromyography EMG. Mechanomyography is considered as gold standard. Acceleromyography most commonly used. Fact-based questions. Can't really help. Fact-based questions. 3 patterns of stimulation: single twitch, train of 4, tetany. Most common pattern, train of 4. Most common pattern, train of 4. Most common pattern, train of 4. 4 stimulations in 2 seconds. That is why it is called as train of 4. 4 stimulations in 2 seconds. Train of 4. Okay. Okay. Identification of the block. Identification of the block. We all know, we have done this thing so many times. What you have to remember is this: fade on top is a feature of NDMR. Why do you see fade on top? Because fading tells you that there is a competitive antagonist at neuromuscular junction, and NDMR shows competitive antagonism. So fade on top is a feature of NDMR. Now DMR, you see constant but diminished twitch height. What do you see? Constant but diminished twitch height. But phase 2 block of scoline, phase 2 block of scoline, when you give excess dose of scoline, it causes a complication called as phase 2 block of scoline, where you see fade. So fade on top is a feature of NDMR, and phase 2 behaves like NDMR. That is why you see fade on top with phase 2 block of scoline. With phase 2 block of scoline. Okay. Alright. We use this TOF to do neuromuscular monitoring, and we use 2 concepts: TOF count, TOF ratio. Can anybody tell me what is TOF count, TOF ratio? What is TOF count? Twitches, number of twitches on TOF. Number of twitches on TOF. TOF ratio is T4 by T1. Ratio of intensity of 4th twitch to 1st twitch. Ratio of intensity of 4th twitch to 1st twitch. Now we use these 2 criteria to decide when can we intubate, maintain and extubate the patient. So for intubation we need to keep TOF count between 0 or 1. For maintenance we need to keep the level 1 or 2. So TOF count helps us decide when can we intubate, what is the level required for maintenance, level required for maintenance. Now we use TOF ratio to decide when can we extubate. So when the TOF count becomes 4, then you see TOF ratio. If the ratio is between 0.3 to 0.7, you wait and watch. You wait and watch. That means the muscle is still significantly blocked, so you don't do anything. Then at 0.7, you will administer reversal, that is neostigmine glycopyrrolate, and at 0.9, you can safely extubate the patient. At 0.9, you can safely extubate the patient. Alright. So we use TOF ratio and TOF count to decide when can we actually extubate and what is the level required for maintenance as well as the intubation. Alright. Alright. Next is a straightforward topic, features of a cylinder. We got one question from it in the pandemic because everybody was wanting to look at O2 cylinder. So you have a gas, you have a color, you have pin index, gas, air, black body with black and white shoulder, oxygen, black body with white shoulder, nitrous, blue body, CO2, gray body, cyclopropane, orange, Entonox, blue body with blue and white shoulder. I have arranged these in the order of pin index for you to easily remember: 152535, 162636, and Entonox is the only agent with one number. You might be wondering, what is this pin index? Pin index is a system of pins on the anesthesia machine and their corresponding indexes on the neck of the cylinder that prevents wrong attachment of cylinder to machine. cylinder to machine. While similar thing for pipeline is called as a diameter index safety system that prevents wrong attachment of pipeline to machine. Pipeline to machine. So two safety features in anesthesia machine, one for cylinder, another for pipeline. For cylinder you have pin index safety system PIS, for pipeline you have diameter index safety system or DIS. Diameter index safety system or DIS. Vaporizers. Now vaporizers are used to deliver volatile anesthetic agents to the patient. Which of the following vaporizer is a special vaporizer? Desflurane. What is the name? Tech 6. That is desflurane, which is blue in color. Sevo is yellow. Halo is red. And purple is isoflurane. Purple is isoflurane. Wonderful, wonderful. You guys are too upbeat. I'm just enjoying this session. You are really great, all of you. Even the ones who are trying to spam, I'm telling you guys are doing a great job, and it takes a lot of effort to even spam the chat box. So full marks to you as well. Next, Mapleson circuits. Now this table describes everything. 6 types of Mapleson circuits, A, B, C, D, E, F, which are obsolete, B and C. So do we need to remember them? No. Only thing to remember, name of C, waters to and fro, canister. Okay. A and D are adult circuits. E and F are pediatric circuits. A is also called as McGill's circuit, another name, and its coaxial variant is called as lax modification. Lax modification. Coaxial variant is called as lax modification. Okay. It is circuit of choice for spontaneous respiration. D, most common use circuit called as Bain's circuit. It is inherently a coaxial circuit. Circuit of choice for controlled respiration. Okay. Then you have E and F. Then you have E and F. Both are pediatric. E is called as Ayer's T-piece. F is called as Jackson and Rees modification of Ayer T-piece. Most of the questions are from name. They are both for pediatric patient less than 20 kg. But if you have to choose between E and F, which one will you choose? Which one will you choose? F is better than E because F is a modification. Okay, F is a modification. Cricoid pressure or Sellick's maneuver. People who are spamming the chat box should stay. They should stay. I'm telling you, you should stay. That will teach you patience. And people who are trying to genuinely attend, they should let the people who are not genuine stay, because that is how you develop focus. Everything is a learning point. Remember, your best friends, they don't teach you that much as your enemies. So always keep friends close and keep your enemies closer. Remember this thing. And so I'm very happy that there are a lot of people here who are not wanting to study, or they're just in a light mood. It's okay, it's fine. No, you don't have to be always focused, and you are helping all the other people realize that their competition is lesser. So you're actually telling them, okay, we should not stress too much. The competition is lesser. There are a lot of people who are not interested. So where do we do this cricoid pressure or Sellick's maneuver? Yes, to prevent aspiration. Prevent aspiration in RSI. In RSI, rapid sequence induction or intubation. Rapid sequence induction or intubation. Yes, RSI is rapid sequence induction or intubation. Where do you give the pressure? The name is only telling you. Cricoid. You push the cricoid posteriorly, blocks the upper end of esophagus. Blocks the upper end of esophagus. Okay. Blocks the upper end of esophagus. So cricoid pressure. You might get an image. You might get a question on RSI. This is straightforward. This is a spinal needle, thin. This is a epidural needle which is thick and it has a handle. This epidural needle is called as Toohey's needle. Toohey's needle. Shorter, stouter. Toohey's needle. This spinal needle can be either a dura cutting needle or a dura splitting needle. Dura cutting or dura splitting. What you see here is a dura splitting needle. Just remember the name Quincase. Quincase. Quincase needle. Okay. Okay. Quincase needle. There is nothing called as modified Salix maneuver. There is only one maneuver called as Salix maneuver. And what do you want me to explain in circuits? We have discussed everything in circuits, right? Everything is given to you. Just read it. Okay. People asking if DVT is enough for anesthesia. I wish I can say yes and I set the paper for you and give all the questions from it. But sadly, I'm not a fortune teller. I can only tell you what is important. I can only tell you what you should read. I can only tell you how much hard work you should do. What is going to come in the exam? Nobody knows, right? So don't rely on any foretellings. Yes, if you read DVT, it is one of the most high yield for every subject. So there are a lot of probabilities of question coming from DVT, but ultimately the questions are in the hands of the examiner, so nobody knows, right? These are IV cannulas and their flow rates. Yellow 24G, blue 22G, pink 20G, green 18G, gray 16G, orange 14G, and these are the flow rates. You have to remember approximate flow rates because different lengths of the cannula can have different flow rates. This is the easiest: 20, 36, 60, 90, 180, 240. Okay. Caudal block. Now caudal block is done in pediatric patients less than 8 years of age. Pediatric patients less than 8 years of age. What do? You mark the two PSIS. You make a equilateral triangle. This is sacral hiatus. And from there you put the needle. It is used in pediatric patients. The dosing is important. Desired level of the block, dose of bupivacaine. This is called as Armitage scale. So if you require only sacral segments to be blocked, 0.5 ml per kg is enough. Lumbar segments 1 ml per kg. Lower thoracic 1.25. Nothing mentioned in the question. Then this is considered as standard dosing, 1 ml per kg. Standard dosing. Okay. All right. Next, let's talk a little bit about anesthetic drugs. I told you integration. We can't keep on discussing everything about every drug. So let's try to apply it to remember. I am giving you surgical condition. We will discuss the concept and the agents of choice. Raised ICP. What is the concept? You want to decrease the ICP. That is the concept. Induction agent of choice, thiopentone. Why? Because it has maximum decrease in ICP. Maximum decrease in ICP. Yes, Quincase is cutting needle. Quincase is cutting needle. I am really sorry. I understood why you are asking multiple times such a simple thing. I am sorry. See, I am distracted now. It can happen to anyone. It is Quincase needle. It is cutting. I'm really sorry. Quincase needle is cutting. Cutting. Yes. Thank you so much for pointing it out. You don't want to raise the ICP. Now, muscle relaxants inherently they decrease the sympathetic response to intubation. There is no cuffing. There is no the patient is not moving too much, so the ICP becomes it doesn't increase. So any muscle relaxant is okay with raised ICP. Inhalational, we know all inhaled anesthetic agents are inherently increasing ICP, so we use SIVO, which has minimum increase in ICP. In remarks, I want to tell you what not to give in a case of raised ICP. Avoid ketamine and nitrous because they increase ICP. They increase ICP. Avoid ketamine, nitrous, or rather at ketamine and all volatile anesthetic agents. All inhaled anesthetic agents. They increase ICP. Alright. Neurosurgery. What is the concept? Neuroprotection. Neuroprotection, that is decrease CMRO2. What is CMRO2? Cerebral metabolic rate for oxygen. Cerebral metabolic rate for oxygen. CMRO2. Here the agent of choice for induction, propofol. Muscle relaxant, any muscle relaxant is okay. Inhalational agent, you don't use actually, you use inhalational agent in the form of again CO, which has maximum decrease in CMRO2, but predominantly you want to use TIVA. What is TIVA? Total intravenous anesthesia, where you want to avoid any inhaled anesthetic agent with the patient. Agent of choice for TIVA is propofol. Agent of choice for TIVA is propofol. Alright. Now cardiac patient, what is the concept? You want cardio stability. Tell me which induction agent is cardio stable? Only one induction agent, etomidate. Muscle relaxant, that will not change the hemodynamics. So you have cis, atra and vec. Cis, atra and vec. Inhaled anesthetic agent, isoflurane. Minimum LV depression. Minimum LV depression. Okay. That is your cardiac patient. That is your cardiac patient. Okay. Avoid ketamine in cardiac patients because sympathomimetic. Avoid ketamine because sympathomimetic. Pediatric patient, what is the concept in a pediatric patient? Ease of administration. So you don't want a painful drug. So induction, ketamine. Muscle relaxant, always prefer atra or cis-atra. Inhalational agent, CO. Inhalational agent, CO. Idea is painless delivery. Idea is painless delivery. Daycare surgery, again, easy or early recovery. Early recovery because you want to admit, operate, discharge the patient on the same day. Induction, propofol. Muscle relaxant, mivacurium more than atracurium. Inhalational agent, sevoflurane. Inhalational agent, sevoflurane. What is the specific feature I want you to remember? Remember, GA is preferred over spinal for daycare cases because you want to discharge. If you give spinal, you should not mobilize the patient for next 6 to 8 hours. So there is a possibility you might not be able to discharge the patient. Okay. ECT, you want seizure inducing property. Seizure inducing property. Which is considered as agent of choice? Methohexytone, which is more than etomidate. First choice is methohexytone, second is etomidate. Muscle relaxant, you want to give scoline. Why? Short procedure. No need of inhalational agent. Why? Very short procedure. Okay. Very short procedure. Avoid anticonvulsants. Avoid anticonvulsants. Yes, for induction we use inhalational induction, but here I am telling you if you have to use an IV induction agent, you will use ketamine. Asthma, avoid bronchospasm. In IV induction agents, you will prefer a bronchodilator like ketamine. Muscle relaxants, cis, atra, vec, rock. Inhalational agent, SIVO. Avoid histamine releasing drugs. Avoid histamine releasing drugs. Avoid histamine releasing drugs. PIH. Now PIH is pregnancy induced hypertension. Okay. The idea in a PIH is to maintain hemodynamics. Maintain hemodynamics. So here remember, you will prefer epidural over general anesthesia. Epidural over general anesthesia. So this becomes mute. You will always prefer epidural over general anesthesia. Heart disease in pregnancy, again epidural over general anesthesia. Epidural over general anesthesia, except there are few conditions where you prefer GA, that is coarctation of aorta, Eisenmenger syndrome, coarctation of aorta, Eisenmenger syndrome. These are the condition, and uncorrected TOF. Uncorrected TOF. These are the condition where you will prefer GA in pregnancy. Prefer GA in pregnancy. Okay. So this is just a overview of how I wanted you to remember these anesthetic agents based on their use. That is the integration that I wanted to give you in DVT. Integration that I wanted to give you in DVT. Okay. Alright. Once again, you have a table, go through it, either go from top to down or go from left to right. Alright. Now let's come to IV, mechanisms of action. Now mechanisms of actions are very, very important. Barbiturate, benzodiazepines, they both act on GABA A, but barbiturates, they increase the duration of opening, while benzodiazepines increase the frequency of opening, right? Ketamine, NMDA receptor antagonist, propofol and etomidate, GABA agonist, NDMR, competitive antagonist at nicotinic acetylcholine receptors, DMR, partial agonist at acetylcholine receptors. Local anesthetics are sodium channel blockers, and intralipid mechanism is early recovery of blocked sodium channels by decreasing cardiac bupivacaine concentration. Very straightforward, very high yield table for you. Just go through it 3-4 times. Principles of working. This is related to whichever instrument we are using. BIS, bispectral index, depth of anesthesia monitoring, frontal processed EEG. Pulse oximetry, Beer-Lambert law. Capnography, infrared spectroscopy. Neuromuscular monitoring, peripheral nerve stimulation. Flow meter, variable orifice constant pressure. Variable orifice constant pressure. Okay. Variable orifice constant pressure. Let's come to complications. Now complications we'll quickly discuss because that is something that is asked very commonly. First is excessive dose or long-term administration. If there is excessive dose or long-term administration of propofol, causes propofol infusion syndrome, which is a multi-organ failure. Multi-organ failure with a cardinal symptom of acute refractory bradycardia. Refractory bradycardia. Along with this, you have one or many of the following: acute cardiomyopathy, fatty liver, rhabdomyolysis, you have hyperkalemia, and you have metabolic acidosis. You have metabolic acidosis. Okay. So multi-organ failure with these features, it is a fatal condition. So no treatment. Fatal, no treatment. No treatment. Okay. Etomidate, long-term infusion causes inhibition of 11-beta hydroxylase enzyme. 11-beta hydroxylase enzyme causing adrenocortical suppression. Adrenocortical suppression. Causing adrenocortical suppression. Okay. Hyperkalemia, beta, why hypokalemia? Hyperkalemia. Okay. Scoline. Excessive administration causes phase 2 block. Phase 2 block. Prolonged duration. Prolonged duration. Atracurium, when you put a long-term infusion, causes production of laudanosine, which can be epileptogenic. Does it happen normally? No. When there is laudanosine accumulation, which happens in renal failure. So when there is a renal failure patient and you put a long-term infusion of atracurium, then you cause phase 2 block, when you cause epileptogenic, seizure inducing potential. Seizure inducing potential. Seizure inducing potential. Alright. Local anesthetic causes CNS and CVS toxicity. CNS is early and mild. CVS is late and grave. The most important problem with CNS toxicity is GTCS, which is treated using barbiturates and benzodiazepines. Barbiturates or benzodiazepines. CVS is a late and grave form of toxicity where there is decrease in cardiac function. So ultimately you have low EF. Treatment is intralipid. Intralipid, 20% lipid emulsion. 20% lipid emulsion. This is very, very important. Very, very important. It has come 3 times in the last 3-4 years. Very, very important. Alright. Now you can give atracurium in renal failure because one, you don't give long-term infusion, and second thing is that there is no clinical significance of laudanosine toxicity. It is only for your MCQs. Okay. Alright. Complications associated with anesthesia. Aspiration is also called as Mendelssohn syndrome. You have to remember there is no role of prophylactic steroids and antibiotics. In bronchospasm, laryngospasm, the first step is to deepen the plane of anesthesia. Deepen the plane of anesthesia. Hypothermia, which is a very specific complication related to anesthesia. 2 things you need to remember. The order of root of loss of heat, that is radiation, convection, conduction and evaporation. Highest is radiation. Gold standard for core temperature monitoring is pulmonary artery catheter. Gold standard for core temperature monitoring is pulmonary artery catheter. Pulmonary artery catheter. Alright. Malignant hyperthermia. It's a genetic condition which is characterized by excessive muscle contraction, increasing the temperature of the patient. Genetic defect, chromosome 19, abnormal ryanodine receptor. Earliest and most sensitive indicator is sudden and abrupt rise of EtCO2. Agent of choice, dandrolin. Remember, dandrolin. How do you give? 2.5 mg per kg given every 5 minutes, maximum 4 doses, that is 10 mg per kg, and then infusion of 1 mg per kg over 6 hours, that is for 24 to 48 hours. Late sign is hyperthermia. Remember, it's an exam question. Late sign is hyperthermia. Most common nerve injured in anesthesia, ulnar nerve. Most common eye complication, corneal abrasion. Corneal abrasion. If you talk about air embolism, most common is venous air embolism. Venous air embolism, VAE. Most sensitive invasive modality is to diagnose venous air embolism is TEE, trans-esophageal echocardiography. Most sensitive non-invasive modality is precordial Doppler. It is precordial Doppler. Precordial Doppler. All right. Now let's talk about intraoperative anaphylaxis. Most common antibiotics followed by muscle relaxants followed by chlorhexidine. In muscle relaxants, the most common implicated is scoline, rock, scoline, atra. Rock, scoline, atra. Most common implicated is rock followed by scoline followed by atra. Post-operative nausea and vomiting. Treatment of choice, ondansetron. Treatment of choice, ondansetron. Alright. And then finally we come to some miscellaneous topics. One that is very favorite of ours, susceptibility of individual nerve fibers to local anesthetic. No matter who tells you what, just remember it is A, B, C. A is most susceptible, followed by B, followed by C. I have given the reference. Read the last two lines. You will know your answer. A, B, C. There should be no confusion here, right? Difficult airway algorithm. In case you have an unanticipated difficult airway, you need to follow 4 plans. What is plan A? Face mask, ventilation and tracheal intubation. When you fail in plan A multiple times, multiple intubators, it is called as a difficult airway. And then you switch your plan. You go to plan B. The next best device is SAD. So oxygenation using an SAD. Third, if you fail to do plan B, then face mask. Final attempt at face mask ventilation and waking the patient up, plan C. And finally, front of neck access, that is emergency cricothyroidotomy. How do you do it? See, this is the cricothyroid membrane. It is a subcutaneous membrane which is avascular. So you take a large bore IV cannula and you put it through that cricothyroid membrane. Okay. Factors affecting pulse oximeter reading. Very, very important. 3 types of factors. False low reading, in which the patient's saturation is normal, but you see on the monitor is lower. Methemoglobinemia, 85% saturation. Methylene blue, maximum decrease, 65%. Indocyanine green, a dye that decreases the saturation on the monitor. Peripheral vasoconstrictive states like shock, hypotension, shivering, and nail paints. Which nail paints have maximum effects? Blue, purple, black. Only one condition that has a false high reading, that is when the actual O2 saturation is lesser but what you see on the monitor is higher. Carboxyhemoglobinemia. No change in the reading. Dark skin, bilirubin, acrylic, fingernails and henna, that is mehndi. Alright. Malam patti classification, that is a most common classification for airway assessment. You do realize, Samkit, now I am enjoying you writing so many times the same question, but I am not going to answer it. I have my own guilty pleasures. Okay, so you can keep on copy pasting it as much as you want, but you're not going to get an answer from it. Okay, so Malam Patti is a classification in which you see 4 things: push, pillar, uvula, soft palate, hard palate. If you can see all the 4 structures clearly, completely, it is class 1. It is class 1. If you can see partial view of the pillar and tip of uvula is missing, it is 2. If you can see no pillar and base is visible, it is 3, and when you cannot see anything apart from hard palate, it is 4, right? When you have a specific condition where you can see epiglottis on mouth opening, that is 0, but it is not a part of original classification. 1 and 2 are potentially easy airways, 3 and 4 are difficult. 3 and 4 are difficult. Okay. All right. Similar system is Cormack and Lehane on direct laryngoscopy, where we see 3 structures. We see epiglottis, we see vocal cords, we see posterior commissure. When all 3 are visible clearly and completely, Cormack Lehane grade 1. When you see a predominant view of posterior commissure, it is grade 2. When there is a hanging epiglottis, it is grade 3, and when no glottic structures are visible, it is grade 4. Tell me which one will be easy, which one will be difficult. You want to intubate somebody, if you can see the vocal cords, easy. If you can't see the vocal cords, difficult. If you can't see, then difficult. Okay. So this is a true laryngoscopic picture, actual laryngoscopic picture, and this is a stick diagram. This is something for your reference so that you know if at all you get a question like this in the exam, how would you approach it. Brachial plexus block, we need to only know very relevant things. Brachial plexus is used for upper limb surgeries. 3 approaches: interscalene, supraclavicular, axillary. Interscalene anatomy is in the interscalene groove in the neck. The structure that you block are the trunks of brachial plexus. It is predominantly for shoulder and upper arm surgery. There is sparing of ulnar nerve which supplies the ulnar segment. So that is not useful for below elbow surgeries. Most common complication is phrenic nerve palsy. Can you tell me in how many % of individuals it is seen? 100% individuals. 100% individuals. Most common used approach, supraclavicular anatomy, lateral to subclavian artery. What you block? Cords, divisions of brachial plexus. It is the area between cords and divisions. Indication: everything below elbow. Perfect block. There is no sparing. Most common complication is again phrenic nerve palsy. Seen in now how many % of individuals? 60%. But most specific complication is pneumothorax. Pneumothorax. Alright, pneumothorax. Last is axillary approach, easiest approach, around axillary artery. What do? You block the terminal nerves, that is radial, median, ulnar. Everything again below elbow. Below elbow. There is sparing of musculocutaneous nerve, so it has to be done via using a separate field block here, and the complication is arterial puncture. Complication is arterial puncture. Alright. So this is about brachial plexus block. Now the last slide that is remaining, it is basically telling you about MET score, that is the metabolic equivalent that is used for diagnosing that whether the patient's cardiorespiratory status is adequate or not. Cardiorespiratory status is adequate or not. Alright. So for assessment of functional activity, we consider one metabolic equivalent as the baseline, that is 3.5 ml per kg per minute. What you have to remember is, if you are able to do these things: standard light home activity, walk around the house, take care of yourself, 1 to 4. More than 4 is adequate. So this is adequate cardiorespiratory status. Cardiorespiratory status. So if a person can climb 1 flight of stairs or walk 1 or 2 blocks on level ground, that is enough for you to consider him from cardiac point of view to consider as fit for a non-cardiac surgery. Okay? So remember, more than 4 is what you have to 100% remember. More than 4. Okay? So 1 to 4 is inadequate, more than 4 is adequate. Now depending on their activity, you have different scales. This is for cardiac patient for a non-cardiac surgery. Cardiac patient for non-cardiac surgery. Cardiac patient for non-cardiac surgery. Okay. Sham, it is not ADA, it is ASA. And if you know ASA grade, then you know it is 1, 2, 3, 4, 5, 6. It's very easy. That's why I didn't include it in DVT this time. Okay. So this is it from my side. And I have already given you the PDF. So please, after this class, don't ask for PDF. I have given you the PDF of life, patience, discipline, faith. Everything that you need for this exam, for your life, is all within you. All you need to do is deal it with patience, develop some good discipline, and have faith in the process. Have faith in yourself, and you're going to do good. I sincerely hope that we made some sense of what we wanted to discuss in anesthesia. It's a very, very easy and an important subject. 3 to 4 questions have gone nowhere. You will always mark them right. I wish you all the very best, and I hope to see you on the other side. All the very best. God bless you. Bye.